pretty easy, right? Not bad. But this is the problem. They have stage 4 renal failure. And I know that I should always check and make sure that the drug isn't cleared by the kidneys, right? Because if it is, we might not want to use the full strength dose. So let's see. We can go into dosing. If you see over on the left-hand side on my screen at least, renal impairment pediatric. This is not a pediatric patient. Renal impairment adult. Look at this. We know that the creatinine clearance is about 22 milliliters per minute. So let's look. Here's the creatinine clearance. If they're above 50, we don't have to adjust. Okay. Then we have from 20 to under 50. Oh, well, this is 22, so we're going to assume that it's this. They fall into this dosing range. So they fall into this. So if the normal recommended dose is 250 every 24 hours, it's not. So we don't care about that. The recommended dose is 750 milligrams every 24 hours. So that's over here. The usual recommended dose is 750 milligrams every 24 hours. I have to give it every 48 hours. Let's think about why. The reason is because since this person is renally impaired, it's going to take them longer to clear the drug. So the drug is going to be in the system for a lot longer. The AUC is going to be much higher. The clearance is going to be lower. So if you think about a concentration time profile, it's going to be a less steep slope. So you only have to give it every 48 hours to maintain therapeutic concentrations because that clearance value is lower. Therefore, the AUC value is higher, so we need less of a dose. That's levofloxacin. Let's look at ephedrine. Let's look at ephedrine. Ephedrine is a stimulant. It's not used all that much anymore. It used to be used as a dietary supplement and an over-the-counter stimulant, although it was taken off the market in the early 2000s, I think 2004, 2003, because of other cardiac risks that it had. All right, so what are we going to use this for? Let's say we're using it for post-anesthesia. I think it's used for post-anesthesia treatments to get the people out of it, dosing adult. Yeah, for anesthesia-induced hypotension, 5 to 10 milligrams. Repeat as needed. It's generally given IV just because if it's anesthesia, you're not going to be awake. Let's look. Renal adult impairment, no dosage provided in the manufacturer's label. Use with caution. So in that case, there's no dose adjustment. That could mean three things. One, it could mean the dose or the drug is not cleared by the kidney. Two, it could mean it's not studied well. Well, there's really only two. Those are the only two. There isn't a third one. So those are the two potential reasons why there isn't any renal impairment dosing. Let's look at the pharmacokinetics real quick. We can actually go down here. Pharmacology and pharmacokinetics. IM within 20 or 20 minutes. Duration, 1 Q sub-hour. Metabolism, hepatic, minimally hepatic. Metabolites include p-hydroxyephedrine. Half-life. So minimally hepatic, it's primarily excreted in the urine, dependent on urinary changes. So in this case, half-life is dependent on urinary pH. So what can we gather from this? Well, this drug is renally cleared. However, there's no dosage recommendations for an individual that has renal impairment. So what that tells me is that the therapeutic index is so wide on the normal dosages of ephedrine that even if you have the levels are twice as high, or if you have the AUC that's twice as large, it's not going to adversely affect the patient enough to warrant adjusting the dose. It has a wide therapeutic index. So that's the third one that I kind of forgot. I mind blanked there. It's just the drug is so safe under a controlled environment that even if the levels are twice as high, it's not going to be a big deal. It's not going to be toxic in that case. So that's what that tells me. All right, sertraline. Let's look at sertraline. Oh, real quick, before we do that, look at here, though. Not only are there renal impairment, let's look at hepatic dosing. In this case, again, there's no hepatic dosing, probably because ephedrine is minimally metabolized in the liver. All right, let's look up sertraline. There it is. Sertraline. Sertraline is used for a few different things. It's commonly used as an antidepressant. Let's take a quick look-see. We have dosages. So, all right, let's see what we're using this for. Let's come up with a dosage, adult. Okay, so it could be used for binge eating disorder, but that's off-label. That means that the FDA did not approve that to be used, but it kind of can be used at your own risk. There's some minimal data that suggests it could work. Hold on, I see a, when you get a chance, it'd be interesting to hear about drugs with diuretic effect. Oh, great question. All right, so, and I see that popped up. I will write down one that is common. Let's look at hydrochlorothiazide after this. Great question. Let's do that. All right, thank you for that. All right, so sertraline can be used for a few different things, right? Body dysmorphic disorder, bulimia nervosa, major depressive disorder, specifically unipolar. That's probably the most common use for sertraline, but I know it can be used for anxiety as well. Let's say it's major depressive disorder in this case. Okay, very common. Initially, 50 milligrams once daily. This may increase. You may increase the dose based on response or tolerability. It's very typical. It's called titrating to effect. Mental health is something that I'm very passionate about. I know a lot about, and that was my last career. Really dealt a lot with mental health, and I worked with sertraline a lot. And usually, what we would do is, if we had a patient that was anxious or that did have suffered from depression, we'd start low and then we titrate up until we hit a maximum of 200. I've seen it a little bit higher than 200. It's not usually recommended. Oh, here we go. Doses up to 300 milligrams a day have been used clinically. Okay, so let's see this again. Let's take the same patient. Not only did the patient have pneumonia, they're also a little depressed. So we need to start sertraline. All right, let's do it. So we're going to go to renal impairment dosing. All right. Dosing, renal impairment. The renal dosing recommendations are based on the best available evidence and clinical expertise. I don't know who Bruce Muller is. I don't know who Jason Roberts is. I don't know who Michael Wing is. But we'll assume that they know what they're doing. Okay. I actually interviewed, other quick thing. I interviewed for Wolters Kluwer. Wolters Kluwer are the people that make Lexicomp. I didn't get the job. It was early in my career, and it was one of the most devastating experiences of my life because I wanted to be one of the people on these editorial teams to actually put this information in there. I didn't get the job. I was devastated, and every time I use Lexicomp, I think of that job interview and not getting that job. It was, it was a cool job. Anyway, so moral of the story, sometimes you win some, sometimes you lose some. I ended up in a great place, so I'm happy with that. All right, so let's take a look. See, altered kidney function, mild to severe impairment. Okay, that's a wide range, right? No dosage adjustment necessary. Okay. However, if they're under dialysis, no dosage necessary. Okay, so it doesn't look like this is renally adjusted. Let's look at the pharmacokinetics. See what's going on here. Pharmacokinetics. There we go. There we go. Anxiety disorder, onset of action, body dysmorphic, yada, yada, yada. Protein binding, right? We'll go more into that. We'll talk about protein binding. It's hepatic. So in this case, this drug is primarily hepatically metabolized. It's not heavily renally eliminated. So that does make sense why we don't have any kind of renal adjustment. With ephedrine, it was different. It was just a wide therapeutic index drug. So it didn't really matter if we had double the AUC. Sertraline does have a lot more toxicity potential, and it's a more narrow therapeutic index drug. But it's almost all hepatically metabolized by CYP2C19 and 2D6 with extensive first-pass metabolism. Oh, okay. See, all these little terms are coming back, right? We're learning the language of pharmaceutics, right? So again, my goal at the end of this class, really at the end of my program, if you're in my program or if you're in my concentration, is for you to be able to navigate this kind of material and know what that means. So cool. All right. So sertraline, this patient, fire away. It's good to go. No problem. How's the hepatic? Are there any hepatic dosing? Let's see. Mild impairment, reduced dose by 50%. Experts maximum 100 per day. Again, okay, so it's mostly hepatically cleared, so it has hepatic adjustment. Okay, and does that make sense though? Think about it. AUC equals dose times bioavailability divided by clearance. When you have hepatic clearance, all of a sudden that clearance is going to go down and your AUC is going to go up. So you want to decrease that dose so that your AUCs are not super therapeutic. Again, a child plow class A, this is not necessarily numeric. This has to be diagnosed generally by a specialist before you do that. You can't just look at a number and correlate it on a table. That's why hepatic dosing is a little bit more complicated. But look at this, moderate to severe, don't use it. Remember last class we said, what are some options here if we need to give a renally clear drug to somebody with renal impairment? One of the options is use a lower dose, but the other is just use something else. There are other antidepressants that we could potentially use. So awesome, great. I'm going to actually look at Charles's recommendation. Let's do hydrochlorothiazide. This is a diuretic, very commonly used to control high blood pressure. It's also known as HCTZ. Hydrochlorothiazide. Boom. All right. So let's talk about hydrochlorothiazide. Hydrochlorothiazide, if you've taken my clinical pharmacology class, you kind of know a little bit about it. It's a diuretic. Well, let's look at here. It's an antihypertensive. It's a diuretic. It's a thiazide diuretic. What it does is it binds to receptors in the kidney, and it causes the kidney to get rid of more electrolytes, and then the water follows those electrolytes. So you end up peeing, for lack of a better phrase, lack of a better term, peeing out more water. The lower water that's in your blood, the lower your blood pressure. It's less volume of blood, therefore you have lower blood pressure. All right, so let's just say the same person with a creatinine clearance of 22 comes in, and hey, they need hydrochlorothiazide. Let's do it. We're going to be treating them for hypertension. We're not treating them for edema, hypertension. All right, so we should be giving 12.5 to 25 milligrams once daily. Okay. But we have to check. They're renally impaired. So we're going to go to renal impairment dosing, adult. Okay, let's see. So it says the renal dosing recommendations are based upon the best available evidence by this dream team right here. Bruce and Jason and Michael, they're on the case. So what do they say? Well, if the creatinine clearance is over 10 milliliters per minute, we don't have to adjust the dose. The diuretic effect is diminished with a creatinine clearance less than 30. But small short-term studies suggest hypertensive benefit may be preserved. Okay, so in my estimation, at 22, well, I guess we can use it. Let's give it a shot. Let's see if it works. If it doesn't work, we should pick something else because maybe the renal dysfunction is worse than we think. Again, creatinine clearance is not a perfect measurement. Maybe it's worse than we think. So let's try something else if this doesn't work. But there's no reason why we can't try this. Let's take a quick look at the pharmacology and pharmacokinetics. All right. It's not metabolized at all. Interesting. So it's not hepatically metabolized. It's excreted in the urine. Up to 61% of it is unchanged. So this drug is not that well metabolized. It is mostly just eliminated in the urine. That hence why, okay, well, if it's unchanged in the urine, okay, I mean, we don't need to renally adjust it for two reasons. One, it's a wide therapeutic index drug. Two, it's not necessarily dangerous. Because think about it, if you have kidney dysfunction, what that means is the diuretic may not work because the kidney isn't intact to have intact receptors to bind to. So the diuretic effect will be diminished. So in this case, we don't have to worry so much about toxicity. We need to worry more about efficacy with this diuretic. And that's why in patients with renal dysfunction, diuretics are a poor choice just because they don't have an intact kidney for the diuretics to work on. So you can see how it does get complicated, right? But my goal here isn't to have you memorize any of this stuff. It's to get you familiar with the concept so you can reason through why these things exist. Because ultimately, one of your jobs may be to come up with these dose adjustments, to come up with these safety parameters for a drug either you're developing or repurposing. So, excellent. That's what I wanted to accomplish. I wanted to show you this in action because this is useful. It's easy to say, well, I'm never going to use this. Maybe you won't, but you have to be familiar because at least when you read literature, you know what first pass effect is. You know what renal clearance is. You know kind of why diminished renal clearance will increase AUC, and therefore it's a danger of toxicity. All right. Second thing we're going to do with our last few minutes is we're going to do a sham analysis problem. All right, let's do it. Let's do it. All right, so problem one, this is going to look very familiar, or there's going to be an exam problem that's going to be very familiar to this. Okay. Sham analysis. Let's consider a 200 milligram bolus injection of drug X. Okay. Plasmic levels were drawn at various times following the injection, which is typical, right? Use a sham analysis to calculate the elimination rate constant, Ke, the initial concentration, CO, AUC, the mean resonance time, the volume of distribution, the clearance, the half-life, and the concentration at 3 hours post-injection. Whoa. Now, the exam is all going to be multiple choice. So this will be asked in each separate question, basically. You won't have like one big question that you have to do all of this. It will be broken up into parts. So this is how I would approach this, okay? What's the first step here? Well, first step is read the question, okay? And the second part of this question, if this is given via continuous IV infusion, when will this reach steady state approximately? Oh, well, let's answer that right off the bat. We know that a drug reaches steady state in about 4 half-lives, right? So once we get the half-life, we should be able to calculate or just estimate, again, the steady state or the time it will take to reach steady state. All right, so let's do it. First step, let's look at this data. Time after dose, 1 hour, 2 hour, 4 hour, 8 hour. Here's our plasma concentration, 9.1, 7.4, 5.1, 2.8. All right, first step is let's graph the data. I already have it conveniently up right here on my Excel sheet, my super sophisticated pharmacokinetic software, right? All right, first thing I'm going to do is highlight this. I'm going to go to Insert. See this? This is the scatter plot. And yours might look a little different, but you get the idea. I just insert a scatter plot here. So we graph the data. Okay, it looks kind of like what we think it would look like. It's an IV bolus, so we don't have that absorption phase. All right. But what's our problem here? Our problem is that we don't have a log transformed y-axis. So let's do that. Click on that. Right-click on it. So at first I left-click on it to highlight it. I'll try to reset it. I right-click on it to highlight it, and then I left-click. I got that confused. I'm sorry. I left-click on it to highlight it. I right-click on it to bring up this menu, trying to be as specific as possible. I want to format the axis. Okay, no problem. I want it to be a log scale. Boom. I like that. So all of a sudden, we're dealing with that logarithmic now, but obviously the x-axis is still linear. Then what I'm going to do is I'm going to click on one of the data points. I'm going to left click on it. Then I'm going to right click on that and format data series. Oh, I'm sorry. Sorry, I meant add trend line. Add trend line. All right, now this doesn't look like what we want because this is a semi-log plot. So we want to go into logarithmic. Watch what happens. Boom. So all of a sudden, or I'm sorry, exponential. Oh, I'm sorry. I'm messing up too. I apologize. Exponential, not logarithmic. Look at how that gets us a nice straight trend line of that data. Then what we're going to do is we're just going to display that equation on the chart. You can display the R-squared value, but that doesn't really do us any good in this case. We get this. We get our base function. I know it's hard for you to see. I apologize. Let me see if I can beef this up a little bit. Okay, so now with this, we can do the whole sham analysis. Why? Because I'm giving you this equation sheet, so you have all of these equations you need. What can we get from this? Well, the 10.4, remember, that's our CO. That's our initial concentration. Because if you extrapolate this, can I draw? I can't draw on this. I don't know how to draw on it effectively. But follow my cursor. If you extrapolate this up, that's the initial concentration, that 10.404. So at time 0, take this. I'm going to move it down. at time 0, this is 10.404. Okay, so we have our CO. Let's go back to the question. We have our CO, done. Also, CO is right there. I have the answers down here, obviously, to show you. But now, what about our K? What about our elimination rate constant, our KE? Well, again, that's right here, 0.167. So we have our KE, 0.167, hours to the negative 1. Got it. Perfect. So we have that. Now, what else do we need to calculate? We have KE, we have CO. Now our AUC. Okay. AUC, we could, how do we do that? Remember, CO, do you remember? We have the AUC, dose times F divided by clearance, but what else could we use? CO divided by, any ideas in the chat? Oh, and I'm sorry, I didn't see this other question. How can we tell what the therapeutic index is, wide or narrow? That really depends on the drug. That takes just experience, and I don't have a great answer for you. You have to actually read literature on the drug to make that determination. I know that because I know the drugs pretty well. But what's an easier way to calculate CO divided by K, right? Absolutely. 10.4 divided by 0.167. Boom, there's our AUC. We got that. Thank you. MRT. So we get MRT. What is MRT? Well, let's look at our equations. MRT is AUMC over AUC, and our AUC is CO divided by K squared. So you just plug that in. We have our K, square it, and then do CO divided by that, and you get your AUMC. Then divide that by your AUC, and you get MRT. And that is, right here. Oh, here's the answer too. MRT. It's 5.98 hours. We're doing the exact same, it's just simple mathematics. Not to give away our answers, but that's okay. I'm kind of showing you how I work through these. All right, now we need to look at, sorry, I'm going to minimize the chat box. VD, volume of distribution. All right, well, let's take a look at this. VD is dose divided by CO. Do we have the dose? Yeah, we do, right? Sure, we have the dose. The dose is 200 milligrams. Do we have the CO? Yeah, 200 milligrams divided by 10.404, and you get your VD. Excellent. All right, so now let's go back to, sorry, I got a lot of tabs open. Oh no, a lot of tabs open here. Push that up. All right, and then we have clearance. So how do we calculate clearance? All right, let's go back to our equation sheet. Clearance? Oh, there's a lot of clearances here. Okay. Well, what's one way we can get clearance? Well, we don't have a clearance right off the bat here, but what we can do, AUC, dose, F. We have all of that, right? We have the F, it's 100%, so that's just one. We have the dose, 200 milligrams. We have the AUC that we calculated previously. We can use that to get CL. There's a few other ways we can play with some equations and get CL, but you can calculate CL right with that equation. Half-life. Half-life's easy. Half-life's super easy, right? All we do is we pull up our equation sheet that you will have. 0.693 divided by K. We have the K. Just divide K into 0.693 and you get the half-life. In this case, our half-life is 4.14 hours. Easy. Got it. So we're almost done with the sham analysis. And concentration 3 hours post-injection. Okay, this is a little tricky, but not really, right? Remember, look at our equations. It's number one of the most important equations we've learned so far. The concentration in the plasma equals the initial concentration times e to the negative k times time. We're trying to find our CP, right? We have our CO. That's 10.404. E is natural. It's E, right? That's a specific number. Raised to the power of negative K. We have that number, right? We have K. It's 0.167. And this is at 3 hours. So we just plug in the 3 for T and solve the equation. 10.404 times e to the negative 0.167 times 3. And you get your CP. Again, scientific calculator, just plugging in values. Not too bad. And we can get that answer. And that answer here, 6.304. Let's do a common sense check. If we know that at time 0, our CO is 10.4 milligrams per liter. 3 hours after we inject it, it sure as heck better be lower than 10.4, right? And it is. Just again, common sense. Always want to. If this is like 30, you know you might have made a small mistake somewhere, because the concentration after 3 hours or after an injection, 3 hours after an injection, should not be higher than the initial concentration. And then time to steady state is just approximately 4 half-lives. 4 times 4 is approximately 16 hours. When you get the multiple choice, it will be very evident. It will not be 14, 15, 16 hours. It's going to be 1 hour, 16 hours, 30 hours, 100 hours. You'll know. So don't worry. I know that that's often a concern for students who haven't taken my exams before. And it's a fair concern. Well, how close is it going to be? What if we did 4.14 hours times 3? I mean, that could technically be close to steady state. It's going to be very evident. Okay? So don't worry. Again, I'm not here to trick you. I'm here to accurately assess your capabilities that I have a lot of faith in. I have a lot of faith in your capabilities. So that's the sham analysis. You're going to basically be doing the exact same thing of what we just did. Okay, so know the ins and outs of that, graph the data on Excel, get that master equation right here. Once you have that, you'll have the equation sheet and go to town. Look at the slides. There's other equations that are on the slides that are not on this sheet. All of them are fair game. It's open book, right? It's open note. You know, that being said, do not wait, or please study for the exam. And I'm going to go ahead and stop sharing this. Yes, the sham is going to be for a bolus. That's correct. It's going to be an IV bolus injection. That's correct. So in closing, what I want to say is please study. What the students that do poorly on my exams, this is most of the time the reason. They figure it's open notes. What's the big deal? This is the problem. If you don't prepare, you're going to be spending so much time reading through notes and trying to find it. You're going to start panicking, and you're not going to finish the damn exam on time. You know, you're not going to finish the exam on time. So study. And then when you take the exam, you'll be like, yeah, I know that. Yeah, I know that. And you'll do well. And most people do well on my exams for good reason. I try to be as straightforward with you on what's going to be on it. I try to ask you fair questions. And I give you the time to do it. Now, you don't have infinite time. You do have a little bit more time here because there is calculations. And I don't want people to get nervous about calculations. I know that I get nervous with calculations. Even if they're simple, I get nervous with them. I understand that. You get a little bit extra time. Usually I give an hour for my exams. You have an hour and a half. It's more than enough time. But, you know, obviously the students that do poorly, they don't study at all. Study and you'll do well. I did have students in the past that tried to coordinate answers, but that never works because all the questions are jumbled for every single person. So you may be on a question, and then these two students that I had were trying to cheat. I mean, for lack of a better phrase. And they both ended up doing terribly. And I could actually track all, because it loads all the IP addresses and everything. And you could actually see that they were on the same IP address. They were trying to coordinate. And their answers were the exact same. And they both ended with the exact same number of questions not answered. So that was unfortunate. But again, the average is always above 80. I mean, so don't worry about it. Just study and you'll do well. Ask me questions if you're having trouble. Don't be afraid to ask questions. If you come to a quiz question you still don't understand, study your quizzes. If you come to a concept that still you don't fully grasp, try to look it up on your own because that's the best way to learn. But if you still don't get it, obviously, I'm here for you. So That's all I got. It's 10 o'clock, went a little bit over. Apologize for that. Hopefully this wasn't too straining for you. I always enjoy catching up with everybody, giving you, some interesting stories and reviewing some material. That's all I got for you. I'll hang out if you have any questions. If you don't, you're free to go. Have a great rest of your weekend. And no, this is not recorded. I do not record synchronous sessions on the weekends because it's more of a participation exercise. And there's no content here that is going to be on the exam that's new. So I don't record it. So that's the answer to that. Thanks, everyone. Have a great rest of your weekend. Email me with any questions that you may have. Take care.